Have you heard of something called central dominance?
No.
So in the face, the central incisors should be the star of the show. It should be in the middle, and the centrals should be like twins. When we lose a central incisor, we have to discuss how was that central incisor lost. And most common cause is trauma. The most important predictor of success of a resin-bonded bridge is the same as it is for veneers. If you're not sure what the treatment plan should be, you probably haven't asked the patient enough questions. Welcome to this back to basics episode on replacing the single central incisor. Why the single central incisor is the most important tooth, obviously, but so that we can just go a little bit deeper into this topic rather than talking about replacement options in general, which we've already done on the podcast. There are certain features which are very special when you're replacing the central incisor and why it is regarded as the most difficult treatment to deliver in terms of patient satisfaction expectations. We're joined by the Protrusive student Emma Hutchison, where we're going to go into the basic overview of decision making. When is a denture appropriate? Is it ever appropriate for a incisor? How about bridges and what type? And what are the implant considerations and actually choosing between these options? I think one of the biggest takeaways you might get from this is communication. There's a specific way I communicate to patients about this, and that's what I think you'll probably take away the most from this episode. Hello, Protrusive, I'm Jazz Galati, and welcome back to the student edition of your favorite dental podcast. I know we call it Protrusive students, but young practitioners or those returning back to work often find these episodes very valuable. Of course, we've got so much more where this came from. We've got all sorts of genres and topics covered in Protrusive podcast. And recently on YouTube, we've done like the playlist so you can actually pinpoint the different themes of the podcast on our app, Protrusive Guidance. Head over to protrusive.app if you're interested in that. It's the community of the nicest and geekiest dentists in the world. We put some extra videos not on YouTube on there as well. Let's now join Emma and I'll catch you in the outro. Emma Hutchison, the Protrusive student, welcome back. How are you doing? How is clinics going? Final year, you've done your exams, but it's the actual more clinical exposure. How's everything going?
Yeah, it's going good. So as I was saying last time, it's just lots more experience this year, which is good. So I'm up in Falkirk in Scotland every second week, just Monday to Friday, 9 till 5, seeing about 4 or 5 patients a day. And then the other second week, I'm in Glasgow doing more specialised stuff, watching some consultants and restorative and things. And so it's good. It's good, just plodding along quite nicely, which is good.
Good. And you obviously have been doing and were a dental nurse. So whilst you're seeing 4 to 5 patients a day, you have this extra level of insight that maybe your colleagues don't have. Like, in the real world, it's, 30, 40 patients, sometimes 12, sometimes 1. Like, it's such a variation because obviously you've been an implant nurse as well. So what advice do you want to give to your colleagues who are maybe listening to this and they're like seeing these 4 to 5 patients and you want to prepare them for the real world? What would you say with your very unique perspective?
Yeah, I think when I was working as an implant nurse, I remember speaking to the dentist I was working with, and he was saying, why he moved to private dentistry initially is just because, the real life just isn't like the gold standards that you're taught at dental school. In the NHS especially, you're time restricted. So I think I do have that in the back of my head that I know that I won't have the luxury of such long appointments when I graduate. So yeah, I'm getting myself prepared for the real world because I am going to do VT or DFT so that I can work in the NHS to start off with and then see where I go from there. But I do know that in the back of my mind, like, it is going to get a lot busier as soon as I start VT practice. So yeah, just to you're not going to have the best materials that you do in dental school. I know in Glasgow anyway, we tend to have really quite good materials, good rubber dam. I know I've spoke to you about things like that before, and just that it might not be like that in real world when I graduate and get out there and start working. So just to prepare myself for that. I'm aware of it, it's fine, and I'm just trying to relish the opportunities that I have at the moment and the staff around me that I have as well. I think that's one thing.
You've got to be like a leech, Emma. You've got to be like a leech, like literally like a sponge.
And just ask all the questions whilst you have all these specialists and consultants around you, and just, take note of everything that they're saying, especially the way that people communicate with their patients, and pick up little things that they're saying to their patients and make it your own. So I'm trying not to wish away my last year. So
no, enjoy the comfort of and the bubble and the protection you get in dental school before you enter the big bad world. Do you think your experience as a nurse and seeing, like, you know, over the shoulder, like, you know, you're suctioning and you're seeing things close up. Having said that, I always find that maybe the nurses, we think they've got a great view, but they often don't, especially when you're like trying to juggle a million things. Because recently I've been using my clinical loop camera more and more. And so now the nurses who've been working for 20, 25 years, they're like, oh, now I got to see what you're seeing, right? So maybe you don't get, maybe it hasn't been that much of an advantage that you come from a nursing background. What do you think about that? Just be honest.
I think initially when I got into dental school, first and second year, it helped, obviously, you know, premolars, molars, all the very basic stuff. And then maybe second, third year, when I start to see patients, you know, I was pretty much at the same level as everyone else. Apart from communication, I've found is the big thing. I found that patient communication is came quite naturally to me, and I think that's because of my dental nursing background.
Because you heard those conversations, right? You were there, present, and you've seen the dentist explain the risks and guide patients to certain sort of treatment philosophies and whatnot. That's a really good point.
Yeah, so I think communication is, you know, doing it yourself is a whole different ballgame. Getting that manual dexterity is something that you need to work on. But even just communicating with patients, I've taken so many tidbits from other dentists and how to explain things to patients. You know, I've worked with a peds dentist, John McCall. I worked with him for a year. So I say a lot of similar things that he did to children, and I get on really, really well with children. And then when I worked in implantology, that's maybe sort of transferred over into oral surgery when I'm talking about those sort of things. So definitely in the communication side of things.
Super. Well, we're talking about more than just communication. We're talking about replacement of a incisor tooth, right? Because I thought, okay, we could talk about replacement of missing teeth full stop, but I just feel that's so broad, right? Like when you talk about a molar to a premolar to incisor. So I thought, why don't we go a little bit deeper into just talking about incisors? You know, let's talk about central incisors, maybe some laterals, that kind of stuff, but just generally somewhere at the front of the mouth, you're missing a tooth, be it trauma or long-term missing, and we'll get into it. But we want to discuss about, okay, what are the considerations and treatment planning options and the delivery sort of little techniques that we can keep in mind, or little details and nuances when it comes to this type of dentistry. So Emma, take it away. What would you like to know in your student lens when it comes to replacing incisors?
Replacing incisors. So I actually had a patient in my outreach centre. So he had a missing central incisor and had done for quite some time. He had a single tooth denture in there, wasn't getting on with it at all. And in student clinic, we have the luxury of our patients don't have to pay anything, and we've got quite good labs on our hands and things. So we thought, let's try an adhesive bridge for this patient. And my clinician at the time said that, you know, replacing a single missing central incisor often considered one of the most difficult things to do in restorative dentistry. So why is it so difficult in your opinion?
Okay, I'm gonna turn the question back on you. What is your perception? Why do you think it's actually more difficult? What did you think?
So I think from my perspective, seeing that patient, he had no other missing teeth, like all his other teeth were natural, a few composites here and there. So I think just in terms of restoring that central incisor, I'm not too sure how to answer this actually.
It's okay. If you're not sure, I'll help you out. But like, I'm trying to understand from a student's perspective. And because I remember this as a student learning this as well, and I was like, wait, why is it so tricky? What are the special considerations for a central incisor where it doesn't, they say the single central veneer or the single central incisor full stop. You're quite right to say is difficult. And I only really appreciated it more and more when I actually started to replace central incisors, how difficult it actually is. Do you want me to go for it, or have you got some more ideas?
Go for it.
Okay. So, have you heard of something called central dominance?
No.
So, in the face, the central incisors should be the star of the show. It should be in the middle, and the centrals should be like twins, right?
Yeah,
centrals should be like twins. And so when you're trying to copy the adjacent central, therein lies the problem, right? Because yes, you may be able to copy the shape, but there might be some compromises. But getting the shade, right? Getting something to look good, okay? And then also, like a really important thing is smile line. When I talk about smile line, what is a smile line? Do you know what that means?
Like how much tooth does it show when your patient's smiling? Or like
Yes,
where your lip
that's
sits?
important, but yeah, where your lip sits, because more important
Yeah.
than tooth is how much gum, actually, right?
Okay. Yeah.
Because if you have a very gummy smile, so a very high lip line, when you smile, like curtains, your lip raises really high and everything's on display. Those are by default considered very challenging cases, because now not only are you worrying about white aesthetics, actual aesthetics of your restoration and the ceramic and whatnot, but now you're also worrying about pink aesthetics, which is the gums, right? How it's so critical, not only for the shape of the restoration to be matching so closely the adjacent tooth, the shade, characterizations, but now with someone with a high smile line, when they smile, that gum contour, it's so critical. And you would have seen this in the implant, like how much grafting and attention, like it absolutely blew me away when I spoke to some of my patients who've had, I'm very lucky, there's a really great dentist that worked nearby me called Rob Oretti. Okay, I don't know if you've heard him. He's brilliant. Okay, a lot of dentists will refer to him the single central incisor. Okay, and he's not cheap, and you know what? And he fully justifies his fees. Like you could buy a small car for we're talking about near five figures. Okay, for a single central incisor. And when I first heard that, I was like, wow, what's going on here? And as I gained more experience and I restored more centrals, I was like, wow, you know what? That fee is totally justified, because when I see his cases, not only is he paying for the top end lab work to try and really match the ceramist, really trying to match that tooth, but more often than not, it's when we lose a central incisor, we have to discuss how was that central incisor lost. And most common cause is trauma. And when there's trauma, there's often soft tissue loss and hard tissue loss, because the bone, the buccal plate, is paper thin. And so what you have with implant is you're dealing with a scenario where you have less bone in such a critical area, and so there's soft tissue grafting, there's bone grafting, and it's all to do with getting really high-end symmetry and aesthetics. That's why it costs so much. So ultimately, central incisors is very tricky, because we're always trying to match to nature usually, or the adjacent tooth in general, and there are soft tissue and hard tissue considerations, and that's why it's difficult. And so the number one thing is, if ever you're replacing a central incisor, even if it's a resin-bonded bridge that your patient you described, you have to explain that, hey, what we're giving you is going to be a replacement, but you have to really tell me how perfect you want it to be, because there's different levels, because the way that a restoration reflects light is very different to a tooth, and they need to understand. I used to work with a consultant called Raj Patel, and then he would basically wave a tissue in the air to the patient and say, what color is this tissue? And they were like, well, it's white. And Raj was known for this kind of communication, right? He'd like be slightly, okay, I hope he doesn't mind me saying this, but slightly, sometimes interpreted as patronizing. Like he'd ask a patient, do you like flowers? And the patient goes, they're okay, I guess. I like flowers. And then like, what do flowers need? Like, and the patients feel like they're patronized. Well, sunlight, growth, like, water, that kind of stuff. And it's like, well, your teeth and gums are like flowers. And so the oral hygiene discussion would come like that. And so I saw him do this, like build a man. I was like, what the hell? Like, what's going on here? So anyway, back to the tissue. He's waving this tissue. And he's like, what color is this tissue? It's like, well, it's a white tissue. Okay. And then he'd put it on his trousers, like over his lap. Right? And so now that tissue is still white, but it looked like, because you see his dark trousers through it. So it's kind of like grayish now. Do you see what I mean? And the patient's like, okay, well, yeah, okay, I see that it's still white, but it's not the same white. And then he's trying to get the patient to understand that, look, we can't match, to adjacent tooth perfectly. He's very good at, and I always took that example. So I very carefully choose the patient through that too. Does that make sense now?
Yeah, that does make sense. And it's the first thing that people see, and the ones that people are more aesthetically worried about are their central incisors naturally. And I don't know if this is maybe good for my first case, replacing that central incisor. My patient wasn't
Have you done it
too
already?
demanding.
That patient,
Yeah,
the denture
I've done
replacement.
it
How
already.
did it go?
It was good, yeah. So we did a resin-bonded bridge, like a Maryland from the other central incisor, but he wasn't too aesthetically demanding. And for this patient, going private wasn't really an option, just financial wise. And he was just happy to have any sort of replacement other than a denture. And so to me, like, it was nowhere near perfect match, but we done the best that we could. His contralateral central was, three different shades in one tooth. You're never going to get it matched perfectly. And with what we've got on the NHS, you pick one shade and that's sort of what you've got to stick with. And he was happy, and I seen him for a review last week and it's still in there, which is good. And he's happy with it. But yeah, it was.
What did you think? Did you, when you, I mean, I don't know if you've got any photos, but like, obviously listeners won't matter. When you look at that central, does the shape match well to the adjacent tooth?
Yeah, he was happy with the original denture that he had in the shape of that tooth. And he wasn't wearing that denture because it was actually broken. And I sent that denture away to the lab as well.
Oh, nice.
I know that they've got impressions of the uppers anyway to match to the other, but I was like, they might as well just have it to see what this patient's already happy with mold-wise. So he was happy with that. I don't think it's too bad a result, but yeah, you can definitely tell that it's it's not a natural tooth that's there. But he was happy with it, and I'm happy with it for my first go. So, but it was tricky. It was tricky.
It's always tricky. Now we'll talk a little bit more about that. But when it comes to replacing that incisor, you did a resin-bonded bridge, and therefore a metal wing, or
a metal wing. Yeah.
Did you find that the central incisor that you were sticking to, the abutment tooth, did it go a bit grey, or not?
Not that I noticed, no. But I know that can happen.
Do you know when that would happen? Which kind of patient is particularly susceptible to that?
Would that be if the tooth has been root treated?
Not necessarily. It's more to do with if someone's got like minimal wear and therefore that incisal translucent zone. Probably this patient. How old is this patient?
He's in his 30s.
Okay, so fine. But did he have a bit of a wear on the edge? Was it a bit worn?
Yeah, a bit. Yeah, he's got a bit of wear. Yeah.
Okay, so sometimes when you don't have much wear, or generally some people have more translucent teeth, right? As a feature of their teeth, and therefore in that scenario you have to warn the patient about graying. And so one thing you could do is you can get a cotton wool roll and we'll take a photo of the tooth as it is, get the retractors in, and then you put a cotton wool roll behind it and you take a photo, and then you see how much impact did that cotton wool roll have on the tooth. Like if the tooth looks different just by putting a cotton roll behind it, then you know that by when you put something black there, that is going to look metal there. It's going to look a lot different as well, basically. And so you've got to warn the patient of that. I've seen some cases that I've done before earlier in my career, which really grayed up. And then one way to mitigate that is to use opaque cement. Now, before we go deeper into that, just remember the main lesson, a really important lesson, is shape with a P is more important than shade with a D, i.e. shape is more important than shade. So if you absolutely nail the shape, that's actually more important and it's going to have a more pleasing outcome than if you get the shape wrong but the shade right. So shape is super important. Always remember that in everything you do. When it comes to anterior aesthetics, shape is always more important when you're trying to match. Did you discuss with that patient any other treatment options, or how did you come to, you and your sort of mentor or supervisor come to the decision that resin-bonded bridges would be the most appropriate, and did you consider any other options?
Yeah, so I think just from hearing other dentists talk about replacing gaps in practice and things, I always go and tell my patients that there's 4 options usually. Does that sort of ring true with you? So the first option is to do nothing, because we always have that option for our patients. The second option was to try a replacement denture for that patient, and he wasn't really keen to give that a go. He's had one, I don't think he even had it for very long, and it had already broken and wasn't very retentive, XYZ. And then I say the third option is to do something more fixed, so like bridge work. And then the last option would be to go privately and do something like implants, and just wasn't in the patient's financial budget at the moment. So he was interested more in going for something more fixed. So I discussed with him that we could maybe do a bridge on that tooth, a Maryland bridge with the metal wing. And I had a chat with him about that, although I didn't actually mention to him about the metal wing and that possibly shining through. And I did have a chat with him. He had quite heavily restored teeth. He had composite on that other central incisor, and on the lateral, it
Was
was
it a big
also quite
composite?
restored.
Was it a
It
large
wasn't,
composite?
I'd say on the lateral, there was quite a large composite.
Okay, but what about the central that your abutment tooth? Did it have a big composite?
It had a distal composite, but it wasn't massive or anything like that.
Okay,
It
good, good.
wasn't
Because having a large restoration in your abutment tooth for reservoir bridge
Yeah,
usually has more negative outcomes because there's
yeah.
less surface area of enamel. Did you know that the most important predictor of success of a reservoir bridge is the same as it is for veneers? So how well your ceramic veneers will bond and reservoir bridges is the same. Availability of enamel and surface area of enamel, and that is really, really key. That's the number one factor when seeing there's going to be success. So it's good that, fine, if it's a small one, okay, ideally unrestored. Okay, so you talk about all those options, and here's a communication tip for you and your colleagues and anyone listening is I used to do the same thing. I used to, okay, there are 4 things you can do and blah, 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 blah. And sometimes, for a lower incisor, right, if you're missing a lower incisor and there's crowding, you could say, well, actually, how about we relieve the crowding and then, like me, have 3 lower incisors. Look, I got 3 lower incisors here, not 4, okay? So you can do something like me and then we can relieve the crowding at the same time. And so sometimes ortho is an option, but obviously it wouldn't be for an upper incisor, right? Because that would look weird. So when we give those options, I think it's much nicer to do it the following way, okay? So Emma, is it important for you to have a front tooth?
Yes.
How important is it? Like you're missing a front tooth and you have a denture and you hate it. How important is it to have a front tooth for you?
For me, very important, yes.
Extremely, right? So really, doing nothing is not an option.
No.
I'm not going to give you that option because that would be inappropriate for what you're saying here. Okay. Is it important for you that it's fixed or do you mind having something removable?
For me, I would ideally like something fixed.
Okay, that's fine. Would you like to be able to eat corn on the cob with it? Or you're not so fussed and you're happy to be a little bit careful with what you eat. What do you think?
Yeah, I'd be happy to maybe be a bit more cautious about what I'm eating. Yeah.
Okay. Do you see, just from those questions, I now know that doing nothing is not an option anymore.
Yeah.
A denture is really an option because you said you want something fixed. Okay, so the only really leaves a bridge. And then what type of bridge? We know the adjacent tooth is minimally restored, so maybe not a good candidate for a conventional bridge where you have to prep the tooth. Okay, so fine, we know it'll be a reservoir bridge or an implant, and both are still on the table here. Okay, both are still on the table. Now, if you said to me that, look, it's really important for you to be able to eat corn on the cob and really to use your incisor a lot and you like to bite into apples and that's really important for you, then I'd say that, look, you're probably best going for an implant. Okay. And then in terms of budget, like is money no question, you want the best there is, or are we on budgetary constraints? And we talk about that. And then we're like, okay, well, actually, based on what you said, that you want to be able to eat corn on the cob in a hypothetical scenario, then really you've got to go for an implant. But because of your financial constraints, then a good compromise will be a reservoir and bridge. This is blah, blah. You explain what it is. But remember that this is essentially an aesthetic appendage. It's something glued. It's for smiling. It's not for chewing. You cannot bite your nails with it. You cannot bite tools with it. You can't bite a baguette and tear it. It will come away. Okay. The worst thing that can happen is it comes away, but you know what? It can be glued back. Okay. But you just have to be extra cautious. And when you have that kind of conversation with the patients, they get it. And if you choose well, reservoir bridges enjoy a very, very high success rate. And the King et al. Study, very famously quoted in Bristol, they had like 700 something RBBs. At 4 years, 80% were totally fine, okay, with no issues. And if they do last 4 years without debonding, they'll probably go on to last 10 years.
Yeah.
Okay. And then beyond. And one thing I can tell you is my predecessor, who I used to work with now, he has been doing reservoir and bridges for years. So I've got patients on my books that have had RBBs for 25, 28, 32 years, never debonded. The odd one debonded 16 years ago once, and then it's been okay. Do you see what I mean? And so my predecessor, using the cements back in those days, did a fantastic job. Case selection was really good. And for all the Americans out there, reservoir and bridges can be very successful, but the patient must play a role. I know that my lower zirconia reservoir and bridge I cannot have corn on the cob. It would be a stupid thing to do. You're overloading it and you'll break the bond. And so those are some important considerations. Now, if the patient would like to be able to chew their front teeth and they're like, look, I want something fixed. I don't have to worry about ever coming away. I want something that'll be to last the longest term possible. then you've now selected an implant. You've self-selected implant. So an analogy I use with the podcast episode I did with Michael Francis, don't know if you listened to that one, Emma, is it's like you're playing Guess Who. If you ask enough questions, right, you only have a few people left, and so really you only got a few options left. So if you're not sure what the treatment plan should be, you probably haven't asked the patient enough questions.
Yeah. I think that's interesting how you were talking about like almost getting the patient to self-select and guiding them into their own treatment option, which is interesting actually, because I'm usually just listing off the 4 options. Oh, we've got 4 options, do nothing, and you're never really going to do nothing if that's that's that patient's main complaint anyway, was that missing central incisor. So that's interesting. And I know you were talking about, so if you're going down replacement options and would you like a fixed versus a removable, what other sort of factors do you consider from a dentist perspective when you're deciding whether a fixed option is appropriate at all or whether a removable option is one that you would more recommend?
Removable is a place, like if it's for a single central, then more often than not, removable is not going to be. It's very much a budget thing, right? Like it's like major budget concerns. And look, I can't afford even the Resin-Bonded bridge, and you got to go for acrylic denture, flipper. Yeah. But there's also things like poor oral hygiene. If they've got poor oral hygiene, it's a double-edged sword actually, because if you've got poor oral hygiene, then you don't want to give them a denture. But equally, if you know they're going to be losing other teeth of poor prognosis, and then you can actually be adding to the denture as you go along. And if they're missing a central, but they're also missing a premolar on one side and another premolar on the other side, and then you can actually replace all those teeth in one go, then that is a consideration. Sometimes when you get a little bit fancy, chrome denture, and you have like palatal backings, and you kind of make like a splint type framework at the same time as part of a bigger case for tooth wear. So there's a lot that can be done, but it's about understanding the patient's history, the number of teeth involved. But if we're talking purely they're missing a single tooth only, which is a front tooth, removable is something that I would struggle to recommend unless it was a budgetary thing. There'd have to be like some really good reasons not to. Now, for example, let's talk about age, right? So we talk about a smile line, but we've got to talk about age, because if it's a growing patient. Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I wanted to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodonture. So it's all there waiting for you on Protrusive guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you do make an account on Android, iOS. If you make it on the website, you get access to the free trial and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description. And thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode. Right, up till the age of 25, you don't want to do implants. Okay, yeah. So therefore, okay, it's a reservoir bridge, for example, or it's a denture until you're old enough to have an implant because it's still growing. And so that's a very, very common thing. And what happens is that they have these reservoir bridges and they're successful for many years, and then maybe in their 40s they end up having an implant. It's much better to have an implant in your 40s than it is in your 30s. And some patients, all they need is just a new reservoir bridge. That's all they need. Yeah. So age is really important, and their growth status.
Yeah, okay.
And then one more thing, like when you're deciding, not so much fixed removable, but you're deciding the type of bridge, if that's other central in your patient's case was already a crown, then you just take off that crown, polish up the prep, and now you have a conventional bridge.
Yeah, and that's what I was actually going to ask you next, because one of my friends had a similar case. There was an adjacent crown, and then there was chats about, what would your approach to that conversation be about taking that crown off? And because I know that there's a lot of dentists would have hesitation around that, to take that old crown off if there's nothing wrong with that crown, to then put a bridge on it. Does that make sense? Does my question make sense?
Yeah, totally makes sense. But the question would be, how old is that crown? And if it's more than about 15 years old, like eventually the replacement event's going to come anyway, whether you like it or not.
Okay. Yeah.
And I used to worry about this as well, but having done several cases now, you get your pulpal diagnosis, you get your apical diagnosis. If everything's sound, you just remove the crown as atraumatically as possible. You just give it a nice prep, give it some love, and you put a bridge on. And I haven't had any issues doing this. And I think everyone's right to be concerned about it, because fair enough, you don't know what's inside that crown. Underneath that crown, that core could have been really weak. So yes, you'd be silly not to warn your patient of like, okay, we're kind of going into the unknown.
Okay.
But I wouldn't want to do this if the crown's like been a recent crown, last 5-10 years. Yeah. But if it's an older crown, it makes sense. But of course, you have to like warn the patient. You also have to find out, okay, how did this tooth fail? Check the periodontal probing depth. If it's like a single isolated pocket and you're worried, could this tooth already be quite compromised and cracked? Then maybe not. Okay. If the tooth already has a big post in it and maybe you're going to be mechanically, you're a little bit worried about it, then maybe the implant is the best way to go. And maybe you should be having a denture until you can save up enough money to have an implant, or if the patient can afford it, go for an implant.
Okay, that makes sense. So if, there's a crown on it about 15 years old, but otherwise looks sound, you're looking to replace the adjacent gap. As long as you've communicated that with your patient and all the risks, you would be happy to go ahead, remove that crown and replace it.
Yes, I would, and I have done it on many occasions, and it is the good option. Because you already have it's like the worst thing you could do is crown a virgin tooth to do a conventional bridge, but you're literally replacing like for like. It's just carrying a Pontic next to it, and again the same thing goes with it, that you got to warn the patient that hey, you got to be careful. This one tooth is now carrying another one. Let's not stretch it by chewing and incising on your front teeth in a harmful way and overloading that unit.
Okay. And just when you're talking about overloading of units there, that sort of takes me on to my next question about, especially in the anterior region, is there any situation where you would prefer or recommend a conventional bridge over a resin-bonded bridge, or vice versa? Like especially in terms of occlusion and things like that as well. Yeah,
so really what you're asking here is, when you're doing a resin-bonded bridge, you're relying on the adhesion, and therefore the point of failure is a debond, whereas you wouldn't typically get that with you feel more secure, you can sleep well at night. Like you made that comment a little while ago where you said you saw the patient review is still there. You probably wouldn't have said that if it was a conventional bridge. right?
Yeah,
Because,
yeah.
you've got the whole 360 degrees, you're cementing it on. It'd be a much bigger surprise if that came away than a resin
Yeah.
bridge, right? So I see where you're going with that. And yeah, if you have a deep overbite, then that is a little bit worrisome because
Yeah.
when they're chewing, right, the time in contact, the time that the lower incisor is thrusting up against that pontic, because the rule of bridges in general is that the pontic is allowed to be lightly in contact in MIP or ICP. But in any excursion, any chewing movements, you want to minimize a rubbing, right? But with a deep
Yeah.
overbite, as soon as you put some food in between, you kind of milling, like you even though it might not be touching, there's still food trying to push that pontic away, and therefore a deep overbite may be a reason. But then again, would I still prep? Would I still prep a virgin tooth to make it into a cantilever conventional bridge? Probably not. I'm probably going to say, look, your functional demands are quite high. Would you like ortho, or would you like to maybe go down implant, which still will have its own issues because we don't want to overload an implant, but probably it's less risk. Now, it also matters about the patient's occupation, because if the patient's a high-level barrister and is doing lots of public speaking and that kind of stuff, you may say, look, with your bite in consideration, then I may suggest let's do an implant here, because
Yeah.
a Resin-Bonded bridge is just glued onto tooth next door, and with your bite, it's a lot of demand. It could still work, but there's a little bit element of risk in there, and you try and ascertain the appetite for risk for that patient, and your patient's occupation as well, the lip line, all those things basically. Because if the lip line's really low and you don't see much, then actually you can get away with a lot more. But if it's really high, not only are you thinking, okay, fine, if you're going to do something, it's got to look good everywhere. And therefore, not only is it just an implant, it's a complex implant where you're doing soft tissue grafting and really trying to get the best out of the aesthetics.
Yeah, okay, okay, that makes sense. And I think that relates to my patient because the reason he was struggling with the denture, a bit had chipped off of it, but he wasn't wearing it anyway. He's a musician, he was a singer, and he was actually at a gig and his denture came out, and so that obviously is not good for him. And he has quite a deep overbite. And I had like a lengthy chat about him, and chatted to the clinician, my supervising clinician, about conventional bridge or a resin bonded bridge. But we were like, let's try it. Let's try it first and see how we go. And it did need a little bit of adjusting. But that's why I was like quite pleased when he came back 2 weeks later and it's still there. We adjusted it a little bit further, but happy with where it's at the moment. But yeah, there's just so much to consider, and yeah, definitely.
I want to remind you and all the listeners that when you do Resin-Bonded bridge, which you guys know I'm a huge fan of, we have the RBB masterclass on the Protrusive Guidance app as well. Have you done that yet?
No, I've not done the full masterclass yet. No, I
Okay,
was waiting
fine. All
until
right.
I was at a point where I understood everything because I started working with you, when I was in second year. So maybe now's a good time. Maybe now's a
Now's
good
a
time.
great time to do RBB
Yeah.
masterclass. Yeah, do it. And so I've got some clinical videos on there of actual
Hmm.
putting bridges on, which you'd like to see. But as part of delivering a Resin-Bonded bridge, it's totally fine to adjust the pontic palatally to make sure it's out of occlusion in that scenario.
Yeah.
You want to check excursions and protrusive movement to make sure it's not
Hmm.
there. But again, equally, it's really important the patient understands that it's glued onto tooth next door, and you must not put anything between the teeth, or you must not chew that baguette. I always use a baguette example, or corn on the cob. And once they understand that, then you'll get success. I had a
Okay.
patient who I did a Resin-Bonded bridge for. I get a very good success rate at Resin-Bonded bridge. I believe in them very much. I do think for a lower incisor, for a single missing lower incisor, the standard of care is the lower Resin-Bonded bridge, central.
Okay.
I think if you're trying to force an implant in that delicate and small area,
Yeah.
why? Why is anyone doing that? I honestly, please, my listeners, if you are routinely advocating an implant for a lower incisor, email me, give me a justification. Honestly, I can't see. I'm a very open-minded clinician, but in that one scenario, maybe it's because I've been affected by this and I'm missing a lower incisor and therefore I have it. I just cannot fathom how you can try and force and try and get a smaller implant, all the complexities of that, when you can just have a Resin-Bonded bridge and just be careful with it. Okay, mine's been going for like 7 years now.
Hmm.
So just remember that you have to look at the patient as a whole and their chewing habits. Just going back to that again, basically.
Yeah. Um, that was actually also one of my questions. You've sort of just answered it there, but you speak about implants for not a tooth replacement, but a missing, I don't know if it's you or if it's one of the clinicians at uni it might be yourself, Jazz, that always says, an implant is a good substitute for no tooth, but it's not a substitute for a tooth. Is that you or a question? Anyway, I've heard that somewhere,
I've
but
said it before, but it's not mine. Like it's from
yeah,
some very clever people. I can't say who. It's one of those things that are definitely said by a lot of people, speakers and writers, and it's a great thing, right? An implant is not a replacement for a tooth; it's a replacement for a gap. Yeah,
for a gap,
and that's or any restoration you do. And just going back to be an implant where you got to manage the occlusion carefully as well, or any form of bridge, especially resin-bonded bridge. Like for example, if you're doing a premolar, I know we're talking about centrals, but I think the premolar example really guides it home. If you're replacing a premolar, maybe you're doing like using the second premolar as an abutment, right? So palatal and occlusal wrapper of the wing, and then you're placing a premolar. Why does that pontic of the premolar need to have a palatal cusp? There's no need. You can literally like put a canine to replace the premolar because ultimately it's aesthetics. When the patient smiles, it should look like they have a tooth there. It's not for chewing. And so the same kind of goes to some degree with the implant where we're trying to make the occlusal table, right? The occlusal table narrower, smaller, so it's taking less load. Now, implants you can chew on implant, like you can go for it, okay? Whereas you wouldn't want to do that on a bridge, so they're different in that regard. But to make the occlusal, really focus on the aesthetics and explain to the patient that this is smaller, that you're missing half the tooth around the back because that's not important, it's not to chew. And if patient doesn't understand that, if they're not willing to buy into that, then you shouldn't be doing a resin-bonded bridge.
Okay. And so an implant supported crown, you talk about that being the gold standard in terms of replacing teeth, but it's not always in certain situations, especially like
lower incisor is definitely not, in my opinion. But an upper incisor, with a good surgeon, then, if you wanted to get something that's going to really be the most secure, longest lasting, then an implant, right? It just makes sense. Would I be happy to have a resin-bonded bridge on my central? I probably would. Okay, I probably would. Honestly, I believe in the treatment protocol. But it depends on like the occlusion once again. Like if you were to do veneers on someone, or if you were to do a central incisor resin-bonded bridge, what's the ideal occlusion to pick? Like if you wanted to give a lifetime guarantee to a patient, who would you pick? What kind of malocclusion or occlusion would you pick? I'll give you a clue there.
A class 1. Wait, sorry, say that again for on the anterior.
Upper anterior veneers or lower anterior veneers. In fact, any aesthetic work anteriorly, who is the best occlusion to work on, which is almost going to give you a lifetime guarantee. Almost.
A class 1.
Okay, if it's a severe class 2, then the lowers for sure are going to last forever. The uppers is always a trauma risk.
Okay, yeah, that's true.
And anterior open bite. No contact, like, anterior open bite, right? This is why, if you look at your anterior open bite patients, their posteriors are worn. The anteriors, they often have mamelon still. The functional load, the wear on those teeth are minimal. So if you wanted to give a lifetime guarantee, the only patient I would ever even dream of doing that is for an AOB, right? Obviously you wouldn't, but I jest, but you get the point, right? So that is a really good example. We teach this in our occlusion courses that we do, where you think about, okay, think of the patient, think of their functional demands as well. Are they what we call a HORP or a LORP, high occlusal risk patient, low occlusal risk patient? And that always plays a part. By understanding that how an anterior open bite actually extends your longevity and prognosis for replacing an upper incisor, it's a level of occlusion that just is more practical and makes sense.
Yeah, that makes sense. And my last question for you, Jazz, was actually just about, a digital workflow and, CAD/CAM milling. Is that something that you utilize in your day-to-day?
I don't do like a chair side making. So like whether you think you're digital or you're not, you're digital. Even if you're sending impressions, when the lab get the impression now, they'll pour it up and then they'll scan the model. And now it's all become digital. Okay. Right? Okay. So everyone's digital, right? Yeah. And so, yes, so I like my technician to, because the shape is so important, they will send me like an exocad file showing me the digital design of the bridge, for example, or the crown or veneer, whatever we're doing. And so I get to see that on the web browser. I get to move around, make it translucent, opaque. I get to suggest some amendments, and then it goes for the milling, and then it gets sent back to me. So it's not like I'm scanning, obviously. So scanning, but what I'm not doing like milling in-house in the practice.
Yeah.
But your lab is doing all those things. So you know whether you like it or not, you are digital.
Yeah. Is that a thing, like milling in-house? Is that a
Yeah, I
thing in
mean, look
some
at
places?
CEREC.
Yeah.
People are doing zirconias and Emaxes, and they've got a little oven in the practice as well for Emax. I don't know if you've ever
Yeah.
worked in a practice like that, or have you
No.
nursed for a practice like that?
No, no, never. No.
I mean, it's amazing. I'd love to be in a practice like that one day. It's like a
Hmm.
whole. I like the idea of same day dentistry. Like you come in
Yeah,
and
yeah.
then they do it all, which is cool. I'm pretty sure you can do good bridges with it, but I see lots of veneers and anterior crowns that are done with it.
Hmm.
And it's great. There's whole Facebook groups. Keep Sarah Kicking is one. I see their work. I'm like, wow, that's amazing. Now you didn't need a
Yeah,
technician for
yeah.
that, and you did it yourself. That's so cool.
Cool. Yeah, I think that's all the questions that I had today, Jazz.
Okay, so the only thing I want to add to that, then, I think,
Hmm.
for completeness, is when you're doing the shade, give as many photos as possible to a
Yeah.
technician. When you're doing the shade tab photo, put the incisor ledge to the incisor ledge, put the cervical of the shade tab to the cervical of the tooth. Don't be afraid to tell your technician, look, I think the cervical is A3, the middle is A2, and then there's white effects here.
Hmm.
The more detail you give, the more closely they will look. Lots of good photos.
Yeah.
You need to make sure that you undersell and overdeliver. So
Yeah.
whether you want to use Raj Patel's tissue technique or whatever, you
Hmm.
got to tell the patient that, look, it's very difficult to match to a central incisor. We will
Yeah.
never match, will never be perfect. Okay. And if the patient's got a problem with that, they can go someone else because,
Yeah.
you run into trouble if the patient's expecting perfect. Because
Yeah.
sometimes we think, oh my God, this is from like my first year in practice. I had this
Mhm.
patient who didn't pay any money towards the bridge because she was exempt. And so
Right.
I did a bridge for her and she was happy overall, except she had a high smile line. And this resin-bonded bridge, the way the pontic sat on the gums, right?
Hmm.
It kind of made a dark line. So we're placing like a lateral incisor from the
Yeah.
canine, and where the pontic touches the gum, at that time I didn't have the skill or the knowledge to do an ovate pontic, right? So it was good, but you can just about see a dark line where she can get some floss under the bridge, right? But you can see a bit of a dark line if you really zoom in. And
Hmm.
she said, look, she doesn't like that dark line, right?
Yeah.
And then I go to my principal trainer. I said, "Oh, listen, what do I do? Like this, the bridge is looking good. We're happy with it, but that dark line."
Hmm.
And the first question he asked me is like, "Well, okay, how much did she pay for the bridge?" I'm like, "She didn't." And he looked at me funny, like, "Wait a minute, she didn't pay for the bridge, and she has a problem with
Hmm.
it." Okay, and actually, I think he was wrong. I actually think he was wrong because it doesn't matter whether. So, firstly, it doesn't matter if they're paying or not. You need to warn of everything. It doesn't matter if they're fee paying or not.
Yeah. Yeah.
I should have explained that. Look, the way this pontic's going to sit against it, you'll feel it. You'll see it. Because why? Because you have a high smile line. You show
Yeah.
everything. So if you want the highest level, you see a periodontist, do some soft tissue work, and
Yeah.
get that kind of stuff done, right? But when a patient is paying a fee, whether they're paying 1 onion or 5 onions, okay, onion can be any currency that you want, basically. If they're paying, just assume that their aesthetic expectations are sky high. And so your job
Yeah.
always is to bring that down to an appropriate level. I'm not saying that always say that, oh, look really bad. Honestly, like you're just going to look so bad. And then when it looks
Yeah.
half decent, be like, hey, what can I say? Don't tell them a lie, but you need to give them like an appropriate, because obviously you want to do a good job for them, but you need to
Yeah.
show them and share with them the intricacies and difficulties of doing that. And then when it comes to decision making, treatment planning for an incisor, just make sure that you ask enough questions so you know exactly
Okay.
what direction you feel confident then recommending that option to a patient. And be it a denture, be it a implant, being a bridge, we've kind of done a little bit of a very brief overview. It's up to
Yeah.
our Protrusive to delve deeper into that. And there's a really good episode that I would recommend. That's we do dentures versus bridges. I did that with Michael Frazis. That's a
Yeah.
good one. We also did one called Crowns versus Onlays with Alan Bergen. That's a really good one. We also talk about dentures with Finlay Sutton. There's so many other episodes out there. So for the students out there, go back in time and listen out there. And speaking of students, we have some student notes. What are the notes that you're adding to the students section of the app?
I think I might even, I've not put it together yet, but I think I might even just take some bits here and there for, just replacement options, not even just for a central incisor, but just for gaps in general. Even just like a communication guide for talking to your patients as well, making sure you're not missing any risks and benefits and alternatives. And yeah, just for replacement options. I think that would be good to put together.
Okay, that'll be available in the Crush Your Exam section of Protrusive Guidance app. There's one thing that we didn't touch on, I just remembered, is when we are replacing with a denture or a bridge, you can actually, we're talking central incisors predominantly, but you can actually have weird and wonderful sizes. Like if you've got small teeth, you can have small pontics, small dentures.
Yeah.
But with implants, we got to really consider the dimensions, the CT scan, how much bone is available. There's a whole biological element which you kind of, to a large degree, can skip with the dentures and bridges. However, the biological for a high smile line is still important, because the way the pontic, the fake tooth, sits against the gum, that's a soft tissue aesthetics then coming in for someone with a high smile line. But you need like a minimum distance between one tooth and the next tooth, a minimum distance between the roots. So sometimes you look at the gap, the central incisor, and you think, yeah, this is great. I can put an implant here. But when you take a PA, you see that the lateral incisor and central incisor roots, they converge. And therefore, actually, you don't have the space. You need to have some very complex ortho to talk and fix the roots here. And so there's so many more nuances. This is why the top dentists that do single central incisor implants, they demand a top fee, because they deserve it. It's very, very complex. And hats off to those clinicians.
Yeah, absolutely. I think if you're putting all that work in, then charge for it. Absolutely. Absolutely.
Good. Amazing, Emma. Thanks so much for being the Protrusive student.
Thank you very much.
Next time, I don't know if you've thought about next time, we were going to consider doing medical histories, guys, but honestly, it didn't excite me enough, because I'm like, okay, am I the expert on medical histories? I can kind of advise, okay, let's open the BNF kind of thing, but it's something that I think is important though, so please do some self-reading on medical histories. But are there any more clinical topics that you'd like to...
What have we not really covered? Bear with me 2 seconds, Jazz, because I actually have a list of...
Okay, cool.
Let's see. We've not really done any basic oral medicine, have we, or oral surgery? I know that we did an extraction topic, but maybe we could do something similar, oral medicine. Oral medicine,
I defer to this really lovely Australian dentist, Dr. Poon. We've done some red patches, white patches, done oral cancer with her. And so it would be a blasphemy if I was to start answering questions on the histopathology of oral cancer and stuff. But we can talk about some other clinical themes. But there has to be... I love it when you have a patient problem. Like, when you have like that, that it's so great that you had a recent patient that had that bridge. So I want you to start looking out for real world clinical dilemmas, because that's what the podcast is about, real world clinical problem solving. So over the next few weeks, have a look at what clinical dilemmas you're facing, and then let's decide the topics from there. I think we'll make it more tangible for everyone that way.
Okay, we'll do that then. Perfect. Thank you very much.
Amazing. And guys, if you've got a recommendation as students for you'd like, or young practitioners, I'm really proud of the series of the previous 17 episodes we have so far. So great. It's really, really good. But if anything else needs a back to basics, something for young practitioners, that's not going to bore me to death, then please do comment and let us know what you'd like. All right. Thanks, Emma.
Perfect. Thank you.
Well, there we have it, guys. Thank you so much for listening all the way to the end. If you are a qualified dentist and you'd like to claim CE credits for this episode or enhanced CPD, you can do it. Head over to Protrusive Guidance or scroll below if you're already logged in, answer the quiz, and claim your CPD. You deserve it. You listened to the whole thing, and now you get to test your knowledge and your understanding, and we will reward you with a certificate. We are a PACE-approved education provider. We've got over 400 hours of CE on Protrusive Guidance, all the masterclasses, episodes, and the accompanying premium notes that we provide, transcripts and infographics, are second to none. Now, specifically for students, we have the Crush Your Exam section where Emma uploads her notes, which helped her smash her exams last year. So the one to accompany this episode will be all the replacement options for teeth, particularly useful for OSCEs and great revision material. Some of the earlier ones that she uploaded was dental materials, for example, which a lot of you found very helpful. If you want to fast track access into that, email student@protrusive.co.uk. Send us your proof that you are indeed a student, and you'll be allowed into that part of the app. Otherwise, thank you all for listening and watching so much. If you're on YouTube, make sure you hit the subscribe and like button. And if you're on Protrusive Guidance, please do comment. I love reading comments and replying to them. Thanks again. I'll catch you same time, same place next week. Bye for now.